Hello, Facebook friends. We are here with our show, Reflect and Reset, with Maria and Gina. Thanks so much for joining us. We're starting. Take care. We'll see you soon.
Talking to the mic.
Hello, everyone. Hi, Gina.
Good morning,
Good
my partner.
morning. Happy Friday, my love.
Happy Friday.
How are you?
I'm feeling tired, but good. It's the weekend.
Yes, I know you're going to Florida.
I'm
so
leaving
you're-
tonight. I'm leaving on a jet plane, as they say, as the radio, as the song goes, right?
I am excited for you. And hello, Dr. Arad.
Hello, how are you? Good morning.
Good morning. We are so happy to have you
Yes.
here today. Dr. Arad is a friend of Fort Maine Medical Center in us, obviously.
Yes.
And he does some work with us, and we try to recommend as many patients to him because we believe in the work that he does, and he has tremendous information to give us.
Yes.
Gina, do you want to make the introduction?
So, Dr. Jonathan Arad is a bariatric surgeon, and his office is in Yonkers. He also has some other offices to make it convenient for patients, New Jersey, Nyack, and the Bronx. So Dr. Arad does the sleeve procedure for patients, obese patients. I'm sure there's criteria for something like that. And then we're going to get into, we're also going to talk about veins that you do, the
Sure.
vein issue. So why don't you tell us a little bit about what you look for, or what somebody, to what level does somebody have to be before they would even consider the sleeve?
Sure, well, thank you for having me. Good morning again. So the criteria for any bariatric surgery is always the same. It's always based on what's called the BMI, or the body mass index. So if someone has a body mass index of 40 or above, they qualify for bariatric surgery. If they have a body mass index of 35 to 39, they qualify if they usually have one of the main 4 comorbidities, and that includes diabetes type 2, high blood pressure, sleep apnea, or heart disease. Anything below 35 by insurance criteria, they don't qualify, but there's always other options as well. The body mass index is basically based on height and weight. Most people usually have to be around 70 to 100 pounds overweight, but it's really based on height as well. So there's no strict weight criteria.
Oh, interesting. And this is covered by insurance.
This is covered by insurance as long as the body mass index criteria is met.
Matches, great, okay.
Why do you think we have such a big problem with obesity in the United States?
I think it's a combination of things. I think it is a lack of education. I think it's part of our culture. I mean, we have a huge obesity epidemic, and it's become worse. We are usually in the top 5, if not the top 2 in the world with obesity, and it's the way that we cook. The cheap fast foods are what people tend to be able to afford, and it's killing America. There are plenty of options out there that can be just as cheap, but they're not as readily available. If you go out to especially certain areas, there's limited options. When you have the major chains around, they are changing some of their ways, but a lot of healthy options don't exist for people that are easily accessible.
So I had a friend that I think I was telling you earlier, who had full bariatric surgery, and I know there's a major difference in that. She had it was like a year this June, and she lost 100 pounds so far. But she has an issue with something called a dumping syndrome, where if she eats a certain amount of sugar in a sitting, she actually can pass out.
Yes.
And can you tell us a little bit about what that is? And you don't do bariatric. I mean, the full bariatric surgery.
So there's 3 main types. There's actually more, but there's 3 main types of bariatric surgeries that exist. There's the band, which is an implantable device that goes around the top part of the stomach and is adjusted through a port that sits on the abdomen. There's the sleeve, which is the most common surgery really done in the country and the main one that I do right now. And then there's the gastric bypass, otherwise called the Roux-en-Y gastric bypass, which is what people call the full bariatric surgery. I've been trained in it. I can do it. I don't really think that most people need that anymore, especially with the results that have been shown with the sleeve. The way that each one works is slightly different. The gastric bypass is a combination of what's called a restrictive and a malabsorptive procedure. So you're making the stomach smaller, but you're also rerouting the intestines for malabsorption. So you're constantly losing nutrients, vitamins, and you're playing catch up for the rest of your life. If you're not on top of that, you can go into severe vitamin deficiencies and loss and have a lot of those issues. You don't really get that with the sleeve because there's not the malabsorptive component to it. It's a restrictive procedure. So what you're doing is you're removing about 65% of the stomach, so you're making it much tighter, almost like a banana shape, what people call the banana surgery. And there's a hormone called ghrelin, which exists at the top part of the stomach. So by removing that part, you're not as hungry. You get what's called early satiety, and you have a couple of bites and you feel full. Dumping syndrome can happen with the sleeve. It's much, much, much less common. It happens more frequent with the bypass because of the connection from the stomach to the small bowel. Because of that reconnection, that's not a normal connection. So when people eat, what happens is the food passes very quickly to the small bowel and they get hypoglycemic, so their blood sugar drops, and it almost feels, when you're really, really hungry, you get sweating, you get palpitations, so your heart's pumping out of your chest, you can pass out, and that's because it's kind of going through the system a little too fast. It happens more with sugar.
She said she couldn't eat more than 10 grams in a sitting.
Exactly, and it actually is not an uncommon thing that happens with the gastric bypass. We don't really see it, again, with sleeves. It's very uncommon. It can happen, but it's much, much less common because the connection from the stomach to the small bowel is preserved in its normal anatomy.
Oh, interesting.
As far as the surgery, the sleeve, right? How does it really work? I mean, long term. So what are the long-term statistics that exist?
Sure. So the sleeve came out approximately 10 to 15 years ago. It's become more and more common. And the sleeve originally came out as an attempt to make the bypass a two-stage procedure. So there were surgeons out there that thought, instead of going straight to the bypass and having a lot of the issues that were happening, let's try to make the stomach smaller, have them lose some weight, and then come back and finish the bypass. And what they noticed is that they didn't need to go back and finish the bypass. The sleeve was doing almost as good of a job as the bypass without having to go there with all the other complications that can happen. And basically the way that the sleeve works is it's not an implant. A lot of people do think that a sleeve is an implant. The band is an implant. The sleeve is really called the vertical sleeve gastrectomy. So what you're doing is you're freeing up the stomach from the surrounding structures. You do it minimally invasive through very small incisions, and you put a tube down the stomach and you use that as the guide to stapling off about 65-70% of the stomach. So you have restriction. There's less stomach, so you can't eat as much. But the other major way that it works is by removing what's called the fundus of the stomach, which is that top portion. You're removing one of the main hunger hormones, which is called ghrelin. So you're not as hungry. People do very, very, very well with a sleeve. There's very few complications. Long-term, the statistics have shown that the sleeve gets almost, if not as much weight loss as a gastric bypass without having multiple anastomoses or connections, internal hernias, leaks, stuff like that.
Can the staples pop?
They can pop, and so we are very, very careful about testing them. So what I personally do, and most surgeons out there do, is we test it a couple of ways within surgery before we're done. So we put it under fluid in the belly to look for bubbles, almost like you would do with a tire. And I actually do an endoscopy where I look inside the stomach and I'm visualizing the entire staple line. The next day, we usually do a test which is called an upper GI, where you drink some contrast. It's a radiologic test takes about 5 minutes, and you do a couple x-rays making sure that
No leakage. Wow.
I have never seen a leak in my life. The technique has become better and better and better. The staplers have become better and better and better. These are the same staples that are used for colons and appendix and everything else we do. But that is one of the complications that we definitely make sure that we're on top of. Again, it's become so uncommon that some places in the country are actually starting to do them outside of hospitals to show you how safe it is. So it's come a long way, and people do very well.
So before we started the show, we were talking about something new that you were saying, that the people that have the surgery, sometimes it's not their fault. The stomach stretches a little bit, and you were talking about a new procedure that was very interesting, because I do have to tell you that I know quite a few people that have had the surgery, and I've seen them, like 5 years later, gradually gain 20 pounds, 30 pounds, and they struggle to lose that. So this gives hope. Can you explain about this procedure?
Absolutely. So there's a couple of different reasons why people will regain weight after surgery. We do explain when we sit down with the initial consultation. It's obviously very patient focused. Everybody's different. We do need to make sure that the patients understand that they have to maintain the healthy diet. It doesn't work by itself. It's a very effective tool, but it has to be used the correct way. But for a lot of people, especially the ones that are undergoing the gastric bypass surgery, the connection between the stomach and the bowel, which is called the gastrojejunectomy, stretches over time. It's a muscle. So like any other muscle, it just starts to dilate, and they lose the restrictive part of the procedure. So they're able to eat more. It's not their fault. It's just something that happens with the technical part of the surgery. And it's actually more common than people think. What we can do, it's very easy. We do an upper endoscopy. We look at the connection itself, and if we see that it's dilated, there's a procedure called the overstitch. It's an endoscopic procedure, which means that there's no incisions. We go through the mouth, and we are able to suture and retighten that connection, giving them their restrictive component of the procedure and putting them back on track. A lot of people are very, very happy. The road to recovery is much faster, and it gives them more hope and more options.
How new is that procedure?
It's relatively new. It's come out in the past couple of years.
And does insurance, is it covered by insurance?
It is covered by insurance. The criteria is a little bit different. It's always based on the size of the connection between the stomach and the small bowel. So it's always requires a upper endoscopy to take a look and see if it's stretched. If it has stretched out, then you meet criteria.
So, I always heard, there's expressions that, not expressions, but actual facts that people don't eat because they're hungry. They eat out of boredom. They don't even realize that they're eating sometimes. It's just so if they go on binges like that, what happens? They get violently ill?
So, it's funny, it depends on which procedure we're talking about. But if we're talking about the sleeve especially, because the stomach is much smaller, it's very hard to binge. Because if you binge, you're going to feel very nauseous, very full, you're not going to feel comfortable, you're going to have this chest pain, and you're going to stop. What we actually see with the sleeve is people forget to eat. Because the ghrelin is gone, the hunger hormone has been controlled, they have to actually remember to eat. But it hasn't been a huge issue. Now, we do tell everybody any of these surgeries can be beaten. Nothing's going to stop a milkshake. Nothing's going to stop some of these other things, and you can binge on those items. We have nutritionists. Everyone who undergoes the procedure has to see some sort of psychologist to make sure that they're mentally ready for the procedure and they understand all this, because it is a different way of eating. It's not the normal way that we eat. It's the way that we should eat, but it's not the way that we normally eat. So there is definitely a lot of support that we offer.
Before we get into the next question, I want to remind everyone that you're listening to Reflect and Reset with Maria and Gina. And they should, if they have any questions, Gina, they can call us up.
Call us at 636-0110, and we're here with Dr. Jonathan Arad.
Dr. Arad, I unfortunately also know quite a few people that are obese, and it pains me to see these, people that I love, and I feel sometimes helpless because no matter what I say, no matter what I try or how we try collectively as a family to help these people, mentally they just cannot accept that surgery is an option. And I've heard
their only option.
Maybe their only option because they've gotten to a place where they've gained 100 pounds, 120 pounds, and they just think that they can do it themselves. And I hear this constantly, and it saddens me because I cannot do anything. They have to take the action, but what I hear is, I know I can do it. If I put my mind to it, I know I can do it. And the answer that I give them is, well, you've been obese for all these years, so then take the action. You've tried to do it. I've seen you lose 10 pounds or 20 pounds, but the thought of losing by yourself 100 pounds, 120 pounds,
No way.
it seems
Very
impossible.
hard.
What do you
No
know?
way.
So it's very hard to do. Obviously, this is a very personal decision for people. I think that it's a combination of kind of a stigma of surgery, that I'm taking an easy way out, I can do it myself, versus the lack of knowledge of the newer procedures that happen. A lot of people still think that bariatric surgery, they hear these stories of these huge open surgeries where people are hospitalized, having all these complications. It's come a long way. It takes about 45 minutes to do the surgery, and people are going home the next day. So it's a very quick turnaround. But it is a very personal decision. I agree. I think that, if someone can do it themselves, I'm all for it. We will help you, we will coach you, we will guide you. But when someone starts to approach 70 to 100 pounds overweight, it is very, very, very difficult to do it yourself. Not that you can't continue to do things afterwards, because that's very important, but to lose 100 pounds on a diet, there are people out there. If you go online, there's going to be people that report that they've done it, but it's in the very small percentage range. It is statistically shown to be very, very rare. This is not the easy way out. This is a way of treating not only obesity, but the medical problems that are associated with it. And that's what I think people need to understand too.
Yeah.
This is not just to look good. This is to get rid of diabetes and high blood pressure and sleep apnea and a lot of other medical problems that happen with obesity. They're directly correlated, and when a lot of people have these bariatric procedures, their medications can go on the shelf. They put their sleep machines away. They get healthier.
I have seen that. People have to understand that, you stay obese and you're shortening your lifespan.
Absolutely.
And, I look at, I have a friend that says to me, well, my diabetes my blood sugar is controlled, but controlled with medication.
Yeah.
I'm like,
Right.
don't tell me your numbers. Don't tell me that your
Exactly.
blood pressure is great. When I go to the doctor, my blood pressure is great, but you're on blood pressure medication, you're on
Right.
diabetes medication, and the risk of, I have a friend that has, these issues with his legs, and he has, is it cellulitis?
Cellulitis.
And when he was admitted to the hospital, he said, "This is it. I am, I'm changing my life, and I'm completely going to lose the weight, and I'm going to do the surgery and all of that." But then he got better, and now it's back to normal.
It goes into a cycle, and that's what people need to understand, that complications happen. Diabetes is so common these days that people just say, okay, I had diabetes. But diabetes is a risk for a lot of things. It's visual loss, and it's kidney failure, and it's heart disease, and same thing with sleep apnea. People just think, oh, I snore. Sleep apnea is a risk for a heart attack and a stroke. It's not something that you want to play around with. So, when people are in a dangerous situation, they start to tell themselves, I'm going to do it. And when they're out of that situation, they kind of go back into their usual routine. But it's very important, I think, for them to see the long-term picture. It's going to happen again.
How do you get them to understand that? Like, that's the biggest challenge.
It is. It's not easy. I mean, because again, it's a very personal decision. I like to sit down and talk to them. I think once people sit down with me and see the options and see that it's not as big as they think it is, and they kind of see the picture in front of them and say, huh, oh, that's
right.
it?
Right.
Okay, fine, all right. I thought it was something else.
Right.
Again, I think there's a lack of just education about it.
But I think they're confusing it with the major surgery.
Yes, I do.
And you know, the sleeve, it's still a bariatric surgery.
Exactly.
So I think that's the confusion.
Exactly,
You know?
I agree.
It's unbelievable though, what they
Yeah.
can do. But you know, Dr. Rod also does veins, so he takes care of varicose? Is it like
Varicose,
considered
yeah.
Varicose?
Varicose and
Which
venous
is-
insufficiencies.
Yes, which is very, very painful, I know, for people. Can you tell us a little bit about who qualifies or, you know, what they look for? I mean, I'm sure it's due to pain, but it does lead to heart disease.
Mm-hmm.
You know, there could be, as we were talking about, underlying issues when you have pains like in your legs
And
and.
you said a lot of people that are obese and have this surgery, they also have this as an issue, and that's why you actually started doing this procedure.
Absolutely. That's, you know, I like to help my patients however I can. So once patients were losing weight, they were having the surgeries, they were doing great. They said, Doc, well, now I have these other problems that were related to my obesity that are now persistent. I have the veins. I want you to help me with this. So we've taken it on. It is a sign of underlying medical problems, especially circulatory problems. And it doesn't have to be, a lot of people think varicose veins have to be the ones that you see in your legs, and that's not necessarily true. There are small ones, the ones that people call spider veins, that are more of a cosmetic thing, but underlying you have a couple of different systems, the superficial and the deep systems in the veins. And when the systems don't work correctly, the blood can't pump back to the heart. And so all of the blood supply that's old and without oxygen sits there and ends up pooling in people's legs and stuff like that, and that causes the fatigue and tiredness and the leg pain that a lot of people have. It's very easy to diagnose. It's an ultrasound done in the office, takes about a half an hour to do both legs, and we kind of map out the entire system. If people want it done, it's an in-office procedure, and it's called radiofrequency ablation. We send up a catheter and we basically collapse the vein by sending little burns to it. The vein collapses and allows the blood to go to where it's supposed to go and get back to the heart.
Interesting.
It happens not just with obesity. I mean, there are any person who is on their feet for a long time, pregnant women, people who, you know, are constantly walking, working, all can have it. Diabetics have it a lot, actually.
I see it in feet, like, I remember my mom, right, and actually my husband, because he's in the restaurant business, he has it in his, like, ankle area, and they're like clusters.
Yeah,
you know?
because that's what's pooling. So what's happening is because the blood can't come up and the valves don't work the way they're supposed to work, they're trying to go against gravity, unlike the arteries that have a pumping system. So when they can't get back to where they're supposed to be, they fall down and they sit and they pool in the ankles and the feet.
Yeah.
So you actually don't have to treat that part, you're treating the underlying quote unquote plumbing. And so by treating that, you're allowing the blood to get back to the heart and actually helps
And
get
that
rid
will
of
heal
all.
so that his feet would,
It depends on the extent.
because they hurt. It's like he's like, you know, don't rub my feet, they hurt.
Yeah, so it can definitely help. Obviously, everything depends on how far it has become.
Right.
Sometimes things are irreversible, but if you don't wait too long, usually it is reversible.
Dr. Rod, before we end the show, because we're getting close to it, could you tell us where your office is and your telephone number?
Sure.
For any of the listeners that want to reach out to you.
Absolutely. So I have multiple offices for convenient locations. I have offices in Nyack, in Bronx, in Jersey City. Our main office is 1088 North Broadway in Yonkers. And the phone number is 914-361-1835. If anybody's interested in any of the stuff that we have to offer and are interested in the other locations, we can definitely give you those.
And we can also, if anyone misses that, you can call us at Form A at 914-723-4900, and we can connect you with Dr. Arad.
That would be great.
Yeah.
I remember when we did a video, you were kind enough to do one of the videos. Form A Medical Center, as everybody knows, we try to really promote a healthy lifestyle and give information as much as possible. And I enjoyed the interview with you because you're young, so you're like, you've been doing this for about 5 years, and you know the latest technology, and you explain things so easy.
Thank you.
And make it okay. I was talking to you and I'm like, oh my God, I could send patients to you and know that you can connect with them, and that's a gift, and I mentioned that to you when we did the interview. But we feel so blessed that you are working with us, and we definitely want to continue to grow with you, in Form A. And where one thing also before we end that I want to ask you, the balloon. Do you believe that this works?
So the balloon is an option. The balloon is not covered by any insurance. It is an option for a certain population. So it's a very quick procedure. It's an endoscopic procedure. So basically a deflated balloon is placed within the person's stomach. It's inflated with saline to about the size of a grapefruit, and it stays there for about 6 months. At 6 months, it has to come out. It's good for people who want to lose about 20, 30, maybe 40 pounds.
So unfortunately, we have to end. This goes so
Okay.
fast.
What a great show.
Thank you so much.
Very informative. So guys, please remember to call Dr. Arad and get in touch with us at Form A,
Yep.
and we'll hook you up.
Reflect and Reset with Marie and Gina. Tune in next
Next
Friday, 9:30.
Yep.
Take care.
Take care.
Thank you.
Bye-bye. Bye, Facebook friends.